we need to look at our patients and individualize the treatment. And so that's why we're going to talk about how the daily lipid use will impact the patient outcomes in the ICU. First of all, we will try to approach nutrition therapy as a treatment bundle, and we will talk about how the different components of that bundle are necessary, and try to explain to you why daily lipids are an important part, as for next to all the other macronutrients that are used in a nutrition strategy. We will also talk about the different fatty acids that exist, and and look at the evidence that exists, especially in a non-surgical ICU population. So I talked to you about a bundle. It is actually like a recipe. If you want to make the best result, well, you need to have all the right ingredients present. You need to make sure that every ingredient is right, and only by using the best ingredients you will get the best result and the best recipe, so that your guest will be amused and will be delighted by your food. Of course, other similarities can be drawn also in other domains of the ICU. And for example, you have the VAP prevention bundle. So ventilatory associated pneumonia is a very known problem in the ICU. And in order to tackle that problem, different aspects need to be tackled. If you only tackle one aspect, you will not have an impact on outcome. However, if you treat it as a bundle and try to improve outcome of the patient and try to implement different components, you will see that the outcome of a patient will be better. And so for nutrition therapy, all the different, you need to look at all these different components. First of all, we need to individualize. And so for the macronutrients who contain energy, what you first need to do is you need to estimate the energy expenditure of your patient. Once you have that energy expenditure and the right number, well, you will need to provide energy in the form of carbohydrates and lipids. But you'll also, in order to rebuild the muscles, you will need to provide enough amino acids and proteins. Also, in order to make the machinery work, you will need to provide trace elements and vitamins. So your patient's mechanism is still working. So how does this, why do we need to measure the energy expenditure? Well, this is because I think you know that is because when you use the predictive equations, well, at best, you will have in 50% of cases the right energy expenditure, and you will overfeed or underfeed your patient. And if that happens, you can give whatever type of nutrition. What happens is you will have more complications. Then, and this translates in this meta-analysis. This is the first figure that you can see here, this meta-analysis by Duan, who showed an impact on mortality when you use indirect calorimetry as compared to the predictive equations. And then once you have that number, once you have that resting energy expenditure that you measured with indirect calorimetry, you will need to provide isocaloric feeding, because if you compare it to hypocaloric feeding, well, you will have also a worse outcome in your patients. And this is actually a trial by Heidegger that I like to show, because it really highlights how you should implement this strategy in your patient. This is also what we do in our ICU, is when a patient is admitted, you start enteral nutrition, and you perform indirect calorimetry between day 3 and 4. Once you have the resting energy expenditure, if you don't reach your goal with enteral nutrition, you will add parenteral nutrition on top of it. This parenteral nutrition contains also lipids, contains amino acids and carbohydrates. And when you use this strategy, you see that you have an impact on your nosocomial infection. And actually, you'll see that your patient will have less complications when he is admitted in your ICU. And your ICU patients are the most fragile one. So these are really the patients where you need to individualize in order to have the best outcome. Now, as for the lipids, in the previous guidelines, actually the previous ESPEN guidelines, they advocated to give at least 8 grams a day of lipids. In the current guidelines, they removed that recommendation because there's not enough evidence to give a right amount to just give a number of lipids that you should provide. They just warn you not to give too much lipids, and so that's why they said, well, you need to not exceed 1.5 grams lipids per kilogram per day. This is a lot of lipids, and you will never reach that if you use ready-to-use uh, emulsions. Now, there also a note of a trial which used only pure fish oils. However, and they noted also in their recommendation that in this trial it also contained the other fatty acids, and so the patients who were treated with this fatty acid emulsions did not have deficiency in the other essential fatty acids. But it does seem logical that you need to provide all of the fatty acids to your patients. How does it really impact outcome, and why is it necessary, and why is it more easy to use daily lipids? It is because when you use more lipids, you will also have a better glucose control. So this is a trial where they compared a group of patients that were treated with, of course, amino acids as part of the nutrition strategy, but also with a mix of carbohydrates and lipids. And the dose, the ratio of both were different. So in the first group, there was 50% was composed of glucose and 50% was composed of lipids, while in the other groups, 80% was composed of glucose and only 20% of lipids. And what they actually saw was quite interesting. Indeed, they saw a better control of the nitrogen balance in the patient that received more glucose, although this could be achieved in other ways, and this was only on day 4. But what was interesting is that you see that the glucose, the glycemia, were better controlled in the patients that were given more lipids in an emulsion that contained 50% of lipids and 50% of glucose. And also the liver enzymes were lower in the patient group that received more lipids, which does seem to imply that it was better tolerated. Now, there was another trial also who looked at the use of fatty acids to glucose control. And so what they saw in this trial, so here I highlighted that you always need to look at table 1 when you look at trials. I highlight that both groups were quite equal and had the same risk factor for death. You see here that when they compared the patient post-trauma with or lipids or glucose, in the group where they were given more, where they were treated with lipids, the glucose was better controlled, and they had less hyperglycemia. And we all know that hyperglycemia is associated with worse patient outcomes, with more infections, and so more complications. Now you have this other meta-analysis that compared patients who compared who did a meta-analysis on all trials in the ICU where they used omega-3 fatty acid as compared to the other fatty acids. And you can see here that they did seem to find an impact on the length of stay in the ICU. However, this meta-analysis should also be regarded with some caution, because when you look actually at the supplemental data, you see that there was a lot of inconsistency in all of the trials that were included. And actually, in another meta-analysis, the meta-analysis of the Aspen Society, who wrote the guidelines afterwards, they did not see a difference in the length of stay in the ICU when they were comparing omega-3 fatty acids. And why is that? Because they, in the first meta-analysis, it was only in the post-operative patients, while in the second meta-analysis by Aspen, you actually see here that they only included all of the trials in the ICU. This, of course, change you, and this is why you really need to individualize your nutrition therapy for your patients and try to choose the best therapy for each patient. And why it also is a little bit worrisome is because indeed in the first meta-analysis they did not see a difference on mortality when they compared omega-3 to the other to the control group who received the other fatty acids. However, in the ICU, the Aspen guidelines also saw higher risk of mortality in the patients that were treated with omega-3 fatty acids, although it was not statistically significant difference. But this will come back in the next analysis. So this is a study published by the Wishmeyer group in which they did a pre and post study. What they actually did is they treated patients 1 year with, so all the patients that were admitted in the ICU, they received intralipids or soybean oil-based lipid emulsions. What they then did, they after 1 year of this treatment, they compared it. They treated patients with SMOF. And what you actually saw here was that there was an impact on length of stay, and the patients who were treated with SMOF had a lower length of stay in the ICU. However, if you really look at the detailed numbers at the other outcome parameters, you actually see that the hospital mortality was higher in that group, although it was a pre-post analysis, because you actually would what you would expect is that in the post analysis, the post group would be better as the medical treatment would be better and better over the years in your ICU. And I didn't include the slide in this. I didn't include the figure in this slide, but if you actually look at table 1, where they looked at the comorbidities, you actually see that the patients in the first year were actually more sick with more cancer and more comorbidities when they were admitted in the ICU. So I think you really should look carefully as when you select your patients to treat, to give the adequate nutrition therapy. And so that is why also the Aspen guidelines do not advocate one form of fatty acids over the other, but I think it's like every healthy diet. You should you should look at the patient and try to provide the best. You should try to provide. You should individualize your therapy and provide the best therapy for the patient. And so this is why the practical implementation in the ICU, you really need to look at all the different components when you're trying to provide the best care for your patient, and when you try to decide on your nutrition strategy. So in our ICU, what we do is we do measure the energy expenditure, and we try to reach our targets of energy by using ready-to-use emulsions because it is more easy. And we also provide enough trace elements and vitamins. So, for instance, if you have a patient that is admitted on in your ICU that is critical ill, what we do after 3 days, if he's not able to tolerate enteral nutrition, we start parenteral nutrition. We calculate the energy to protein ratio of the patient, and we match the best parenteral nutrition to that patient. We started at a certain amount. We do perform indirect calorimetry at day 3, and we adapt the rate of the parenteral nutrition. We have 4 ICUs in our center, so pragmatically on Monday and Thursday in 2 ICUs, we perform the indirect calorimetry there, and the other 2 ICUs, it is on Tuesday and Fridays that we do indirect calorimetry, and we adapt the rate of the parenteral nutrition. We, of course, every day we try to evaluate if it's possible to feed our patients enterally. And then on Sunday, we try to perform a nitrogen balance. And if needed, we will increase our protein delivery in our patients. Because if you try to make things simple, well, we do have more times for difficult things in our ICU, in our complicated patient. So if we can conclude, we use daily lipids because it is in accordance with the strategy, with the nutrition strategy that impacted outcome and where you will have an impact on mortality and morbidity. You will also have a better glucose control. But it is true that we do need better trials to look into our general ICU patients with type of fatty acids can be used.
Be sure to watch for upcoming Channel One videos on nutrition and learn more from our esteemed colleagues. Have a great day.